Welcome to the St Emlyns podcast. I'm Ian Beardsall, and in this special episode, I chat to Steve Smith, ECG blogger and educator extraordinaire, who I'm sure will be known to many of you through his website, Dr. Smith's ECG blog. Over the next 20 minutes or so, we talk all things occlusive myocardial infarction and why that's different to an ST elevation myocardial infarction, lots and lots about ECGs, and even more excitingly, about the future of artificial intelligence and how it may one day get rid of what I like to call the ECG thrust. All of the references that Steve mentions and much more is available on the blog site at stemlynsblog.org. And as ever, please do like and subscribe. And if you have friends and colleagues who haven't yet had a listen to the podcast, this might be a great episode to start with. Thanks again for listening, and I hope you enjoy this episode. It's a huge pleasure to be with Steve Smith, who many of you will know from his worldwide fame as an ECG blogger. I think most of us have taken most of our ECG knowledge from Steve over the years. I had the pleasure of meeting him about a decade ago, I think we were just saying, Steve, at one of the SMACC conferences. And thank you so much for joining us. We're going to cover a few things today. We'll talk a bit about the blog and its background. I'd really like to hear more about occlusive myocardial infarction and what that is compared to ST elevation myocardial infarction. And most importantly, we're going to talk about artificial intelligence. But first, Steve, why don't you just introduce yourself for anybody who might not know who you are?
Sure. Well, I've been in emergency medicine for 37 years. I started at Hennepin County Medical Center in 1987, and I still work there. I teach the residents and the students. I got interested in EKGs all the way back in 1989 when I was working in the cardiac care unit. We had to make the decision on whether to give thrombolytics or not. We had to make sure that the EKG was not a false positive, especially because we didn't want to cause intracranial bleeds. And then I started noticing all the subtle signs of occlusion on EKGs. So I decided I was going to write a book on it. It took me a while, but in 2002, I published the ECG in acute MI, an evidence-based manual of reperfusion therapy. In the meantime, publishing many peer-reviewed articles. And in 2008, I started Dr. Smith's ECG blog, which was one of the first FOAMed sites in the world. Actually, it's still free. It always has been free. I've now got 1,700 posts on there of all kinds, a lot of rhythm cases, a lot of OMI cases, and various other things. But mostly concentrating on OMI because I find that to be the most important aspect of the EKG. In 2014, I came to SMACC in Australia and talked there, and I thought more about it during that and thought, the STEMI non-STEMI dichotomy is a false dichotomy. So I started giving a talk called that, the false STEMI non-STEMI dichotomy. Later, I realized we just have to rename it. We have to come up with a new paradigm. Let's call it the occlusion MI or non-occlusion MI because ST elevation is such a bad way of diagnosing acute coronary occlusion. It's not sensitive, it's not specific. And so we published the OMI Manifesto in 2018 online on my blog. Then I started talking on let's replace STEMI non-STEMI with OMI-NOMI. We've published many papers on this. I've got over about 70 peer-reviewed papers on ECG, on the electrocardiogram, and recently many on the OMI paradigm. We've shown, for instance, that my reading in EKG is twice as sensitive as the STEMI criteria for diagnosing acute coronary occlusion.
The occlusive myocardial infarction. So I think if you ask any cardiologist in the UK and most emergency physicians, they will describe ECGs, I am looking for ST elevation. And sometimes they'll say they're looking for left bundle branch block. And that's kind of what they're looking for. I think what you've challenged and said is that ST elevation is a very blunt tool for finding patients who have occlusion, and that's what we're interested in, the patient who needs to go to the cath lab, who needs that occlusion unblocking, and we need to try and find something different to do that. But are you getting a lot of resistance from people who just hold on to the STEMI idea?
I get resistance from a lot of people. I get acceptance from a lot of people. And everybody wants more data. They want a randomized trial. Well, no one realizes that there's never been a randomized trial of ST elevation to thrombolytics or percutaneous coronary intervention versus not doing it. They're holding OMI to a higher standard than they ever held STEMI to. There is a lot of data. For instance, there's Koyama published all the way back in 2002. He took STEMI and NSTEMI all to the cath lab emergently. What did he find? 55% of STEMI had TIMI zero flow, i.e. completely occluded artery. 45% of NSTEMI had a completely occluded artery. And they both had 5% mortality, very similar outcomes. In 2017, Kahn did a meta-analysis of all studies of NSTEMI that they could find. These were randomized trials of various kinds. They took 40,000 NSTEMI patients. And of course, as with all NSTEMI patients, they did not get their angiogram until the next day. 10,000 of those 40,000, or 25%, had a completely occluded artery on next day angiogram. Those patients, compared to the NSTEMI patients with an open artery, had double the mortality, much higher biomarkers, worse LV function, and that all in spite of the fact that those patients with STEMI were on average 15 years younger and had fewer comorbidities. And then since that time, there have been more studies looking at the same thing, STEMI versus STEMI. And the patients with STEMI have far higher mortality, 1 year, 5 year. Aslanger and I published a study out of Turkey where they looked at 3,000 cases, 1,000 without myocardial infarction at all, 1,000 with STEMI, 1,000 with STEMI. We had cardiologists who were trained in OMI recognition on the EKG to decide on the STEMI patients which ones were OMI and which ones were not OMI. 28% of the STEMI patients were diagnosed as OMI by the EKG, blindly, not knowing the outcome. And those 28%, and of course, because they were STEMI, they did not get, this is retrospective, they did not get emergent cath lab activation. Those 28% whom you could identify by the EKG blindly had far higher mortality over 800 days than the patients who did not by EKG have OMI. So we've proven that looking at the EKG and finding OMI has much higher mortality than patients without it. We have not done a randomized trial of it. Would you like to be a patient with an occluded coronary artery and be randomized to not getting your artery open? I don't think so. On one hand, you could say it's not ethical to do so. On the other hand, you could say, well, that's what's happening right now is people with acutely occluded arteries are not going to cath lab until the next day because they don't have the required amount of ST elevation. I mean, it's absurd, really, to think of it, that is happening all over the place right now, and no one's doing anything about it. But it's perfectly accepted that if someone has an occluded artery, but they don't meet ST elevation criteria, it's perfectly acceptable to let them sit there with their chest pain and have their myocardium dying.
For people who haven't read the blog, ST elevation is a relatively easy concept to understand. You learn about the leads, you learn about what you're looking for. What should people be looking for when they're looking for an occlusive myocardial infarction, the OMI?
For one thing, subtle ST elevation can also be due to acute coronary occlusion. Now, of course, some subtle ST elevation is not, so it becomes difficult to tell which ones are and which ones are not. But if you have any reciprocal ST depression, for instance, if you have a little bit of ST elevation in lead 3 and any ST depression in AVL of any amount in a patient who's got acute chest pain, it is almost certainly an acute coronary occlusion. And we proved this. One of my residents, Joanna Bischoff, and me published that paper years ago. Another situation, left anterior descending artery occlusion, can have much less than the required amount of ST elevation. How do you tell the difference between normal ST elevation and LAD occlusion? Well, I derived and validated a 4-variable formula which uses the R wave amplitude in V4 and the QRS amplitude in V2 and ST elevation at 60 milliseconds after the J point in lead V3 and the corrected QT interval, and comes up with a value which with a cutoff of 18.2 is extremely sensitive and specific. Now, these rules are very hard to use. I mean, that has been out there for 10 years. It's on MD Calc, that rule, but it's still barely ever used. Then we published a paper in the Journal of the American Heart Association showing that any ST depression of any amount in V1 to V4, if it's greater than the ST depression in V5 and V6, is 97% specific for acute coronary occlusion. Do people still do that? I don't know, but that's a posterior MI. V2 and V3, to have any ST depression in those leads is extremely unusual, and if it's in the setting of acute chest pain, it is an acute coronary occlusion, a posterior OMI, until proven otherwise. And so we've published many other rules of this kind, like the Smith modified Sgarbossa criteria for left bundle branch block, we derived and validated, and the Smith modified Sgarbossa criteria for ventricular paced rhythm. So I've been doing this for years, looking at all different ways of codifying what I can see on an EKG, but it's still very hard. Even the modified Sgarbossa rules are hard to apply. It takes a certain amount of skill and knowledge that is hard to learn. So I've always thought that the way to approach this is AI has to do it. And we've managed to teach AI how to do it. So I think that's the future, and really it's the present now too.
I think it becomes pretty obvious that I was trying to write down some of those things you were saying as you were saying them, and I can't keep up. And I've looked at your blog loads of times, and I don't remember half of this. But the idea that having a machine that we can tell to look for it makes a lot of sense. I would suggest to everybody that if you haven't seen Steve's blog, go and have a look. Firstly, it will just astound you because you will see ECGs where you think, well, that's fine. And then you read the description and the outcome and think, oh, I've got a bit to learn here. But until we get the AI into all of our departments, we have a responsibility to make sure we're as good as we can be. But Steve, it does feel like this development into AI makes sense. AI feels like it's taking over our world a bit. It can recognize all sorts of stuff. So it makes sense it can recognize ECGs. What brought you to that point where you were able to take the step of, I've got an idea, this is how I'm going to make it happen? How did you go from, I'm really keen on ECGs, I think this could be an idea, to where you are now with a working model?
Yeah, well, for at least 20 years, EKGs are like faces to me. I look at it and I instantly see that it's an acute coronary occlusion or it's not an acute coronary occlusion, and I don't have to measure anything on it. It's like when I see you, Ian, I know you're Ian. I don't have to measure your nose or measure your eyes or measure your mouth to know you're Ian. I just know you're Ian. And I know that computers, AI, can recognize faces just as well as I can. So if it can recognize faces like I can, it ought to be able to recognize EKG faces like I do. So for at least 15 years, I've been hoping to come to this point. In 2014, I started working with an AI company in EKGs called Cardiologs out of Paris. And I kept telling them over and over, you've got to focus on diagnosing OMI. And they were just obsessed with diagnosing rhythms, especially atrial fibrillation and wearables. And this is what all the AI people in EKGs have been concentrated on for the last decade. It was hard to get them to listen to me that really the biggest problem in EKG is diagnosing OMI. I finally have gotten to the point where people are recognizing this, especially Powerful Medical, which had me train their system. EKG is a face. AI can recognize faces. It should be able to recognize an EKG.
So how did it go from, well, how did you find Powerful Medical, which is the company that I know we should be upfront, I think you have some now financial involvement with, although I would imagine it's not buying your house quite yet. How did you get from an emergency physician in Minnesota to being a person who's then got this company involved? And because I think they're based in Europe, aren't they?
They're based in Bratislava, Slovakia. The reason that they have developed a system that can digitize EKGs, that's one of the essentials of having AI do this, is being able to take like all the EKGs from my blog, make a digital file out of them so that AI can work with that digital file. And no one else has been able to digitize EKGs like that. The reason they are able to is in Slovakia, they don't record EKGs in digital format. So from the beginning of the company, they had to figure out a way, because their country was behind technologically, they had to figure out a way to leapfrog that and be able to digitize the paper EKGs that they have. So they could take a photo of a paper EKG that had been crumpled up and turn it into a digital file that AI could analyze. So that was one essential part of it. And the other, they found out about me and they contacted me and asked me, can you teach our system? If we put thousands of EKGs on a platform, can you code them as OMI or not OMI, and then teach our system that way? And I said, I've been waiting for this call for a decade. Yeah, I can't wait to do it. And my research partner, Pendle Myers, we do everything together. He and I then on the platform, we just coded EKGs for several months. And that was all it took to train the system. And we're working on version 2 now, which is going to be a lot more complicated. But as far as the financial considerations, I just have to say, I've been working on trying to save people's lives from coronary occlusion for 30 years. My blog has been free. I've never needed the money. I've never wanted the money. This is not about money. This is about saving people's lives. And I believe we've found a solution to save people's lives and save them from getting heart failure.
I've used the app and the program quite a few times, actually, and it's been, well, revelatory in some ways. So you've got the app. I think Powerful Medical had made an app where they were looking at heart rhythms because that kind of was what people wanted with their wearables or whatever. And then they've added this bit on, which you've called the Queen of Hearts. The Queen of Hearts is the bit that you and Pendle have taken and educated in occlusive myocardial infarction. So you have managed to teach this artificial intelligence to recognize ECGs in the way that you do, or at least hopefully in the way you do. Has that actually been borne out in trials and evidence where you've compared the AI generated answers to your answers to people like me, ordinary people?
Yeah, well, I'll tell you about 4 studies. The first study we did was on a database of known outcomes from Aalst, Belgium, thousands of patients. The outcome of OMI was TIMI 0 or 1 flow or TIMI 2 to 3 flow with a culprit. It's not a perfect outcome measure, but it's the best we could do. And we found that the Queen of Hearts had double the sensitivity at a fixed specificity. At a fixed specificity of 98%, the Queen of Hearts was 68% sensitive, and the STEMI criteria were 34% sensitive. Then we did some other studies. At my own hospital, we looked at pre-hospital cath lab activation to see how it helped decrease false positives. There, in a certain time period, there are 117 cath lab activations by our medics. Now, our medics, they believe in OMI already because I'm there teaching them, and And so out of those 117 cath lab activations, we looked, there were 48 that we could classify as actual true positive OMI, and 69 were false positive, were not OMI. If we applied the Queen of Hearts to these EKGs, it detected all 48 OMI and decreased false positives from 69 to 29. It could really decrease false positives. Another study we did was in Aalst, Belgium. They have already implemented the Queen of Hearts in their system. It's approved in the European Union and in England. And so they just, every patient with chest pain, they apply the Queen of Hearts. And historically, non-STEMI, which have occlusions, have had a median time to intervention of 16 hours at Aalst. In our 2.5-month implementation, there were 11 NSTEMI OMI, non-STEMI, that had an occluded artery, and they were recognized immediately by the Queen of Hearts and had a median time to intervention of 1.4 hours. So we went from 16 hours to 1.4 hours by implementing this. A doctor doesn't even have to look at the EKG. There were 6 false positives. The false positives, one was a myocarditis. Those are notoriously difficult to differentiate from OMI. There was a Takotsubo, which is also notoriously difficult to differentiate from OMI. And then there were 4 other cases that were canceled by the doctor because the patient did not have any symptom that would have been worrisome for OMI. So those were the 6 false positives, but it detected the 11 cases that otherwise would have had delayed angiography. We have dozens of ongoing studies right now at all over the world, both retrospective and prospective, and so we're coming up with more data all the time.
So as an emergency physician in the UK, and I think this will resound with lots of people wherever they're practicing, I can see this for one big advantage, and I'd be interested to know whether you think the Queen of Hearts would work for this. We get the ECG thrust all the time, and you probably recognize that. Everybody, it seems, gets an ECG in the emergency department, even if you don't have chest pain. Just because you're tachycardic, you get an ECG. You've got a headache, you've got an ECG. Everybody gets an ECG because, hey, it doesn't do any harm. We can go into whether it does or not another day. But these are then taken by somebody and they are literally thrust in front of a doctor of varying skill and experience or clinician. And they said, okay, can you sign this ECG, please? And that doctor is stopped from doing their work. They then have to look at something. They ask some questions and the whole interaction seems to take minutes and gets in the way. Is there a place whereby we could, with a decent evidence base, put this into our department for every, for want of a better term, triage ECG that's done, and that would be safe?
Yes. Let me tell you about another study that I'm analyzing the data right now. It's not published yet. I have a collection on my blog of 51 cases of acute coronary occlusion that were diagnosed by the conventional algorithm, whether it be Veritas, Marquette 12SL, GE, any of those algorithms were diagnosed as completely normal, and yet they manifested OMI. And I could see on all 51 of the EKGs that it manifested OMI. There's 3 publications so far that conclude that a doctor does not need to be shown the EKG if the conventional algorithm says it is completely normal. Like I'm saying, 51 cases where the conventional algorithm said it's completely normal, but the EKG actually was manifesting an acute coronary occlusion. So I gave those 51 EKGs to the Queen of Hearts. She diagnosed 38 of the 51 as OMI. The other 13 she said were abnormal, but did not diagnose. She did not say they were OMI. So in every case, she recognized that it was an abnormal EKG, and those are the ones that need to be shown to the doctor. She did not call a single case of OMI as normal, unlike the conventional algorithms, which diagnosed 51 of them as normal.
We've been used to that idea the ECG machine gives us a little printout at the top, which I'm guessing, I have no knowledge about, but I'm guessing that the intelligence behind that is utterly different from what we're talking about here. Those algorithms that are used by the machines are not the same high-level AI you're talking about and that you've developed. Can you see an environment whereby in my emergency department, we get hold of the app and every ECG is scanned by the app, we can keep it on our records, and if it says there is no occlusive myocardial infarction and no other abnormality, or it's normal, you would be confident in your reading of the literature, confident to be able to say it will not miss bad outcomes. And if there's anything abnormal, that will highlight it. So that could be our first filter in the emergency department.
Yes. I mean, I can't say it will never miss something, but I can say that it will do way better than almost any physician and way better than any conventional algorithm. Remember, conventional algorithms are just taught there's code, if then, if this is that, then this is that. It's not a learning algorithm like AI is. I can't guarantee it will never miss one or never overcall one. There will always be difficult EKGs that can't be diagnosed even by the Queen of Hearts. But I can say I would feel perfectly comfortable in my emergency department having the Queen of Hearts screen every EKG without a doctor looking at it.
And I mean, my experience of when we've had a few of those missed cases, I had one at an M&M meeting not long ago. It was being discussed, and a lot of my group haven't heard of the AI type idea for this particular thing with ECGs. I put it straight in, and it told me exactly what the end of the M&M presentation was, which was this person had a bad outcome. And it was a really visceral demonstration of how powerful that can be. How far away, Steve, do you think it is from this AI going into ECG machines itself? Will that ever happen?
Oh, it will happen. I don't know when, though. That takes a lot of negotiation with the big companies that make the ECG machines. And I hear about the business side of all this every now and then, but that's not my role in the company. And so I don't really know how those negotiations are going, or I think that they probably won't happen until we get FDA approval in the United States. I think that will happen within 12 months, probably earlier.
Just for our UK and European listeners, what does it mean if you were to get FDA approval?
If we got FDA approval, that means we could sell the device. It's called a device, even though it's just an algorithm. We could sell the device in the United States with the FDA approving that it's a useful and accurate device.
So is the app not available in the US at the moment?
You can use it on a trial basis. Anyone can use it. Whenever I put a post up that shows the Queen of Hearts in action, I put a link in there. In fact, today, I just have a post up today where you can click on the link, get the Queen of Hearts for free and use it all you want. And so there are thousands of people around the world using it right now, but they're not, and they're using it for free. It's like a beta version.
And so next steps, I've bought into this a while ago, Steve, and we're trying to do some work in Southampton with you to try and see how we can, there's so many ECGs that are done in the world. It's not like we're looking for the cases, is it? And I'm bought in with the occlusive myocardial infarction. I can get on board with that really well, actually. What do you think the next steps are for people who are listening now? What would you say they should do? Download the app and have a look, see how it works. What would you say would be the next steps?
For individuals, download the app and use it. See how you like it. Well, I'll tell you one story. There's a newsletter called the Expert Witness Newsletter, and he writes cases that were malpractice cases that went to court and had decisions and had awards, jury awards and multi-million-dollar awards, and learned about the Queen of Hearts. And he thought he wanted to go back to a case that had been a malpractice case where a woman came in with chest pain, had an EKG recorded, and she ended up dying, being sent home and died. And he thought, well, I wonder what happens if I apply the Queen of Hearts to this EKG. And he did, and it was OMI with high confidence. Then he thought to himself, he said, I had been following the OMI, NOMI paradigm for a long time, and I was skeptical of it because I didn't think that physicians had the skill to read EKGs to that kind of accuracy about whether the patient has an occlusion or not. And then I heard about the Queen of Hearts AI, and I thought, well, I got to test this out. So he tested it out on this case, and it turned out it told OMI with high confidence. Then his thought was, well, I wonder if it's calling everything OMI with high confidence. So he used it on a bunch of other cases, and it was giving accurate outcome of not OMI when it was not OMI. And so he became a believer in this, and that's when he sent out the Expert Witness Newsletter last week with this case reanalyzed. One's personal experience with it is really powerful because you can use it on any EKG you want and see how it works. Now, you got to remember that critical to any test is the pretest probability. So I would not advise using it on people with toe pain, all right? If someone's you got to be thinking, this patient, I'm worried about this patient having an acute coronary occlusion. You're worried about that clinically, then you apply the Queen of Hearts. And if it says OMI with high confidence, it's very accurate. If it says not OMI with high confidence, it's also very accurate. There are some false positives, false negatives still, so you still have to, do serial EKGs and maybe echocardiogram, and sometimes you just have to do an angiogram if you're still worried. But it is way more accurate than any human except maybe me, and it is really good for your patients. So try it out. The second thing is anybody who wants to test it out formally and study it, we have protocols that we're helping people do clinical studies on it. And we want to aggregate all that data and have a very big multi-center study showing how well it works or how well it doesn't work. Either way, please, get in touch if you want to do that sort of thing. And we can get you started on if you're really serious about doing research, we can get you started on such a protocol.
So for listeners who've probably sitting there with their mouths open thinking, this could mean that I no longer have ECGs thrust in front of my face, there is a way forward, which is if you've done an ECG in the emergency department, a decent idea of first pass, put it through the Queen of Hearts, which the app is called PM Cardio, I think, Steve, isn't it? If you look in App Store.
PM Cardio, there's an app in Android and Apple. Just type in PM Cardio and you can get the app. In Europe and England, if you get the app, you get 5 free uses and then it costs money.
A decent start would be you've got an ECG in the emergency department, have a go with the app. It's incredibly easy. All you do is you open the app up. It says add a new page, and that opens your camera on your phone. You take a picture with your phone. It asks you for some very basic demographic details, which I'm guessing, Steve, add a bit to the pretest probability of age, sex, and then you're asked a few symptoms as well. Have they got chest pain? Is it a routine? That sort of stuff. And then literally in seconds, it will then analyze the ECG for you and give you a probability of occlusive myocardial infarction, but it will also look at other stuff as well, won't it? So it'll diagnose bundle branch blocks and rhythm disturbance and all those other bits and pieces as well.
And hypertrophies and on and on. Yeah.
All of the stuff that you're really wanting in that first pass. For me as a senior emergency physician in the UK, if I could take that stress away from our more junior clinicians who are thrown into this environment where they're not sure what to do when they're given an ECG, sometimes I'm not sure what to do. If we were able to do that, I think it's a good thing. I'm delighted to have Steve on the podcast to explain more about it. If you do want to download it, go to Steve's blog site, which is Dr. Smith's ECG blog. You can find that on Google. Whatever you do, go and look at the blog site. And Steve, I can't thank you enough for coming along. I think it's a really exciting time. And hopefully in a year, we'll be able to report on the FDA approval and it'll be getting even bigger.
Yes. Thank you so much, Ian, for having me.